permission of the chair. We move on to the last presentation, that's heart failure with ejection fraction above 40%, therapeutic armamentarium. We'll have Dr. Umeshwar Pandey, Professor of Cardiology at the LPS Institute of Cardiology, GSPM Medical College, Kanpur. That will follow with the 8-minute discussion. Professor Pandey, please.
So what is the therapeutic armamentarium in the heart failure with ejection fraction above 40%? So according to the universal definition of the heart failure, symptoms and signs of the heart failure caused by the structure or functional cardiac abnormality and corroborated by at least one of the following, which is elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. This is according to Joint Position Papers, European Heart Journal 2021. So now you already aware the less than ejection fraction has been already discussed by Dr. Ashish Jha. And second is half MRF, means heart failure with mildly reduced ejection fraction between 41 to 49. And after that, more than 50%. Now one entity is now newly introduced is heart failure with improved EF. The patient previously come to us with the ejection fraction of less than 40%, and now after taking the treatment, he is land up into more than ejection fraction 40% group. So we call this heart failure with improved EF. This is very, very important. You already aware that stage E is the patients of, all the patients of diabetes and hypertension, pre-diabetes, pre-hypertension, stage B, stage C and stage D. Previously in the hospitalized patients, in 2005, the most of the patients are in the range of the subset of half RAF. But now the changing landscape of heart failure is putting the most of the patients of half PAF in hospitalized patients. So we are seeing the most of the patients are half PAF now onward. Half PAF patients are mainly older patients, female patients, more hypertensive, more diabetes, and CAD is more common in half RAF. Apart from that, renal failure, obesity, atrial fibrillation and chronic lung disease are more common in half PAF. And what about half MRF? Half MRF is already similar to half RAF patients, and most of the characteristics are same with the half RAF. Cardiac pathophysiology is different than the half RAF patients. Mainly it is due to diastolic dysfunction, impaired relaxation and increased passive stiffness. This is a diagnostic criteria algorithm. The echocardiography is the main diagnostic algorithm backbone because of this 3 subgroup divisions. So I would like to emphasize more on this newer slides which is published in European Heart Journal this month only. It clearly shows that this half RAF patients in first your visit, first echocardiographic done and the patient labeled as half RAF, means that less than 40%. After second echography, after 6 months of follow-up, the few patients of half RAF converted into half PAF and few patients of the half RAF converted into half MRF. So we should do echocardiography in every patient of your OPDs. And after second echocardiography shows the more or less same subgroup are maintained over the period of time. In this studies also shows that if half MRF is decreasing EF, shows more mortality. So what is the principal management of this half RAF and half PAF? Half RAF is already told by Dr. Ashish Jha, diuretic, and diuretic, this subgroup is also same. Treat congestion. Second philosophy is treat precipitating factor, which is more important in the half PAF patients. And the third is treat perpetuating mechanism. In HFrEF, target endocrine activations and its sequelae, but in HFpEF, target microvascular inflammations and its sequelae. So the risk factor management more important in the HFpEF patients, like we encourage the patient's sedentary life, cigarette smoking we should ban, control obesity, control excessive alcohol, control diabetes, dyslipidemia, CAD and CAD more strictly in this subgroup. HFpEF treatment option are already, diuretic has been already well told, well established. Hypertension, we should use ACE inhibitor, ARBs, beta blocker. Atrial fibrillation, beta blocker, CCB, digoxin, amiodarone. And in diabetes, ACE inhibitor, ARBs. And in CAD, all the four fantastic. What about HFMRF? According to ESC newer guidelines shows the diuretic is a class 1 indication. Apart from that, ACE inhibitor, ARBs, beta blocker, MRA, sacubitril valsartan, all are class 2B, not even class 2A. And in the HFpEF, means the more than 50% of the EF group, screening and for treatment of etiology and cardiovascular, non-cardiovascular comorbidity is recommended in patient with HFpEF. This is class 1 and diuretic is a class 1 indication. Meta-analysis of the studies patient with the HFMRF and HFpEF patients. All of the studies shows mildly benefit or no benefit and p-values not almost significant in these meta-analysis. But newly published Emperor Preserve trial shows the empagliflozin has been shows benefit in the CV mortality and heart failure management and p-value is most significant in this study. When we see the subgroup analysis, HFMRF shows the NNT is 21 and HFpEF NNT 42. Means that empagliflozin has shown more benefit is HFMRF. You already aware the mechanism of SGLT2 because this has many pathways. So it has mortality benefit in HFpEF and HFMRF. Recently published European Heart Journal 2022 CSA Kerala registry has been clearly shows that if the patient of upper dotted line is, black dotted line is HFrEF with no GDMT and lower dotted line is HFMRF with no triple therapy. If we give the triple therapy, the mortality benefit is much more. And this registry also shows that if admission is more, the mortality is more in near futures. So we should integrate and comprehensive therapeutic study in the heart failure with preservation fraction. Like we should symptomatic treat by pulmonary congestion, pulmonary hypertension, muscle deconditioning, and the controversial role of this usual recommendation in HFrEF life, ACE inhibitor, ARBs, MRA, beta blocker, and ivabradine. And we should consider tighter control than this HFrEF. Hypertension should be totally tight control, overweight should be controlled, renal dysfunction should be intensely controlled, and as other factors also. Newer therapies like resynchronization, renal denervation, some interatrial shunt studies is going on, but they don't much in this subgroup. And above of all, this is all pharmacological therapy, we should not underestimate about the lifestyle management like exercise training and patient education. So the take home message is HFpEF is an underdiagnosed entity in the present era. We already label as COPD, but most of the patient is preserved HFpEF patients. Most important is a strict risk factor management and lifestyle modification, regular follow-up including echocardiography at least after 6 months in every patient of the heart failure. Diuretic and SGLT inhibitor are now the drug which form the cornerstone of the treatment of this subgroup, and triple therapy might be useful in the HAF MRF group. Thanks.
Thank you very much, Professor Pandey. Ladies and gentlemen, the next 8 minutes, may I request our chairpersons to kindly take over the proceedings. Thank you.
Thank you all speakers. They have done wonderful jobs. You want to ask something and my panel experts can ask something.
Yeah, just one small comment for Dr. Jamwal. Musculoskeletal symptoms are very common with statin therapy. We all face them in our clinical practice. Some of these are real, but we feel most of these can be perceived as well. So if the CPK levels are not very high, which generally is the case, patient can continue to take statin if they are clinically indicated with assurance, good hydration and lifestyle modification.
Yes.
Not all of these would need some change in the therapy.
I think there's a statin myalgia score index that's been provided. I think this score is actually beneficial in such cases where there's a confusion.
Very true. Most of the patients won't have high CPK levels. I mean, they would have normal or at the most borderline. So it's very uncommon, relatively uncommon to have CPK levels more than 4 times where we have to modify the dose.
Right.
Yeah, regarding this statin and muscle symptoms, we must remember there is also a nocebo effect of the statin. Meaning when a patient knows that he is going to have some symptoms, he is likely to have more symptoms. The nocebo effect is well described in the ARAHAT trial. So we must understand and we have to reassure the patient that you are not likely to have symptoms which warrant stoppage of therapy.
Right, so patient should not be told about side effects in advance. I have two specific questions, one to Dr. Azharuddin. The topic was how to go ahead in chest pain with non-specific ECG changes. So here is a patient who is having T inversions, not hypertensive, not diabetic, no other thing. What will we do? That is the commonest problem. We have seen everything. What should we do now?
So baseline ECG?
That is what I am saying, non-specific STT change. So
If-
what should we do?
Yeah. If it does not, the change is not evaluating
Nothing, nothing.
biomarkers. In this era, in widespread availability of high sensitivity troponin at admission, at presentation, 0 are negative, undetectable high sensitivity troponin in a setting of low probability, like a female who's
We have done that, it's negative, nothing is helping.
patient can go home. And pending that, the next step is he or she does not have ACS. That does not mean he does not have CAD.
So
Further
how to go,
evaluation.
that is the point, how to go ahead?
So he does not have CAD, but depending
At the
on,
age of 70, he still can have CAD.
yeah, he does not have ACS. He can have CAD. Further evaluation would be dictated by his pretest probability. In a low likelihood scenario, CT
70
outperforms
70 years,
70
no
years.
diabetic, no hypertensive, no other risk
He would
factors,
already be
enzymes
candidate
normal,
for therapy.
BNP normal, echo normal. What to do? That is the common problem.
So in a chronic stable scenario, we have to first diagnose whether he has CAD or not. So that question is of immense importance, because if he has CAD, and then he would be candidate for prophylactic therapy. Now,
I
the
understand.
best investigation in this current era to make this distinction is not physiological testing. That is anatomical testing.
Yes,
Of
Dr.
course,
Sir,
there is
anything?
evidence and other experts may differ.
Let me add here. See, in this scenario, I'm in a position to answer this because I covered the topic for the national CSI. See, you have a patient who's 70 years of age, non-specific pain. As you said, he might still have coronary artery disease. He comes into the intermediate category.
Yes.
The general recommendation is that if you have a low or a low intermediate probability, you go for CT coronary angiography. But at age 70, where you have a intermediate to high intermediate probability, you will go for a reversibility testing, which will be a nuclear scan. After he said, when you discharge the patient, you ask the patient for a reversibility testing. That is what I can make out of this. If you have
So,
something else in mind, maybe...
No, I don't have anything in mind because this is a question common.
One comment. there has been head-to-head comparison between anatomical imaging and physiological imaging. When treadmill testing or stress testing was compared head-to-head with CT, this is a randomized control trial. CT outperformed because in reversibility testing, we missed
See, the
CAD.
populations differ, populations differ.
This has been amply
Populations differ.
debated,
You can't.
and the current consensus, as per the European Society of Cardiology, is that you need to use the two investigations as complementary to each other and not substitute for each other. So there's no head-to-head in all the populations.
Dr. Azhar, they are all different patients. So it's a common day-to-day problem. The subset of these patients, nothing, no problem except age. He still have at least intermediate age probability. So he will be dealt differently and more aggressively than a 25-year-old or 40-year-old because the underlying disease is likely to be there. So what he is saying takes precedence that you are likely to find a CAD in them. So what to do? That is the point. Second question was to the Dr. Ashish Jha. He talked about the reduced ejection fraction, and now we know there are 4 pillars. So he said start the therapy, and it's again a common problem. We're sitting in an outdoor, the patient has come, he is congested, his blood pressure is 90/100. You are not able to start ACE inhibitor because of blood pressure, you're not able to start beta blocker because ejection fraction, he is not euvolemic also. Can we start diuretics, dapagliflozin and ivabradine at the same time along with digoxin till the other drugs start working?
Sir, the evidence base for this is not there, but it's logical and often this is what is done. But
What would you do? Would you start dapagliflozin straight away?
So first I'll start him on diuretic and low dose of diuretic. I'll add dapagliflozin if his
What will be the point where you will add, and why that point? Why not now?
Okay. So because sir, when diuretic and dapagliflozin are given together at a higher dose, there may be a chances of further diuresis and dehydration and fall in BP, and maybe we'll be able to add ARNI and ACE inhibitor at much later stage than is needed. So first, if I have to add, I'll put them on diuretics, and if diuretic dose also cannot be very high, then I'll add low dose diuretic plus gliflozins.
So these are common problems which come in the
There cannot
OPD.
be a,
You can give ACE inhibitors, beta blockers, diuretic. Yes, Bansal.
I was expecting in your talk that there would be a mention of the different sequences which have been, proposed. John McMurray has exactly proposed the sequence that sir is saying.
I had gone through that article, sir.
Yeah.
But
So use a DAPA and beta blocker or ivabradine.
But that was that was one of the suggestions that has not been
No.
validated in the-
This
I've
cannot
gone
be a
through that.
guideline.
Yeah.
Absolutely correct. This cannot be a guideline.
And
So
what that guideline, what McMurray had suggested was that you add these 3 first and then you add ARNIs on this thing. But I think the evidence base for ARNI and or ACE inhibitor and beta blocker is much stronger than...
certainly. The point here is that you have to see what I think and get from the article is, if the drug is not altering hemodynamic profile and improving outcome, start it. So dapagliflozin may come as the first, and then you do other things, because ultimately you have to have all 4 drugs.
Okay, I'm extremely sorry for the interruption, Mr. Chairman. We have totally run out of time.
Okay.
So with your permission, we'll have to move on to the next session. I'd like to thank the chairpersons, members of the expert panel, and the speakers.
Yes, go ahead.
One common question that OPD prescription in patient with heart failure with EF more than 40%. HFpEF, it is an old entity, no significant addition apart from SGLT2. The most important entity is now HFpEF, heart failure with improved ejection fraction. Now we have a patient who has been started on heart failure medication. One is who is SGLT naive and the one who is MRA naive. So guidelines say that you have to go on full heart failure treatment in these patients so that they go on improving.
Absolutely.
So in these 2 subsets, whether we go with addition of SGLT2 whether we go with the addition of MRA.
MRA.
Sir, I would like to add that in...
No, I want to say something, sir, if you allow, sir.
Sure.
So in this subgroup, this is very, very delicate issue. So we should take the measurement of blood pressure. What is the blood pressure? If your blood pressure is low, we should give all other treatment like ARBs, ACE inhibitor or SGLT2, ivabradine, sacubital. And diuretic is the cornerstone. Even in the HFpEF patient, this is class 1 indication. No doubt about it. No doubt about it. And SGLT2, no doubt about it. We should do lower dose, dapagliflozin, 5 milligram should be started. If you hesitating diuretic effect more over
I think the discussion will continue.
Yeah, we'll have to move on. Thank you.
Diuretic you mean MRA, not...
My purpose was to just initiate discussion. I think it will continue now.
Thank you very much, Professor Dwivedi and the members of the expert panel and the co-chair, and also the speakers. Ladies and gentlemen, we move on to the third session. That's hypertension, diabetes and metabolic syndrome. We've got 4 speakers. Each speaker would have a time of 12 minutes, followed by 3 minutes of discussion immediately succeeding the presentation. So if the speaker finishes within 12 minutes, we'll add that time along with discussion. If he crosses, then we'll not be able to take up the discussion. So with these few words, I'd like to invite the chairpersons. Please welcome, in the order of appearance, Dr. Atul Agarwal, Senior Consultant Cardiologist at Chiranjeev Hospital and Heart Center, Lucknow. Professor Umeshwar Pandey from LPS Institute of Cardiology at Ganeshankar Vidyarthi Medical College, Memorial Medical College, Kanpur. The members of the expert panel, Dr. Piyush Saxena, Associate Professor of Medicine in the Cardiology Unit at Motilal Nehru Medical College, Prayagraj, Uttar Pradesh. Dr. Rashi Khare, Senior Consultant Interventional Cardiologist in charge, Heart Failure, Fortis Hospital, Shalimar Bagh, New Delhi. Dr. Harendra Dev Singh, Senior Consultant Cardiologist and Director, Krishna Heart Center, Jaunpur. And Dr. Vivek Raj Singh, Senior Consultant Interventional Cardiologist at Vardhan Heart Center, Varanasi. May I request the first speaker, with the permission of the chair, to deliberate on secondary and refractory hypertension, Professor Bhuvan Chand Tiwari, Head Department of Cardiology at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Professor Tiwari will have 12 minutes for